guys, this is Dr. Sajid. I'm one of the GP trainees here in the Northeast. Whilst I was preparing for my exams, I thought maybe just perhaps have a look into explaining NICE guidelines. So I was reading through a few of them, thought I'd just start reading with you guys as well. Today we'll be reading through the hypertension guidelines, the first bit where we diagnose and confirm the diagnosis, and then in the next video we'll go forwards with the management of hypertension as well. I see this a lot in my clinic, that's why I've picked it up. And we'll keep it as clinical as we can. We'll see how things appear in the clinical practice and then try to correlate it as much as we can overhead. So the guidelines, they're the NICE guidelines, and I'm just going to explain them as we go through them and put in my clinical approach, how I felt, what was necessary, and how it helped me become a better doctor at the end of the day. They start off with how common is hypertension, and then the hypertension causes. This bit is a bit the epidemiology. We might not be touching upon it. The hypertension causes are a bit theoretical, like we've talked about before. They're about primary and secondary hypertension, primary being essential with no identifiable cause, and secondary one tends to have a large workup with the cause in behind. Next up are the risk factor for hypertension, and I think this was particularly important because we've got two types, the modifiable and non-modifiable. It's important because when you're counseling the patient regarding lifestyle changes, these are the few things that you can target about. A few of them are weight, salt intake, physical activity, alcohol, and stress. So if we were to have a patient in our clinical setting that's got high blood pressure, and he wants to start the tablet, but he wishes to look for lifestyle modifications along with as well, these are 5 things that we'd want to counsel about: the weight, the salt, the physical activity, alcohol, and stress. Non-modifiable factors are age, family history, ethnicity, and gender. Sadly, we can't do much about that, can we? Moving on, I think this is it's a bit of a tricky spot. It's defining hypertension, and we've got about 1, 2, 3, 4, 5 definitions. We've got masked hypertension and white coat hypertension. Masked being higher at home and then tends to be lower whilst they check on the monitor or if they come into the GP, and the other way would be white coat whilst they've got it higher and it's the stress by the GP that brings out a bit higher of a reading. These are the 2 easy ones, and then we've got stages of hypertension. So there are 1, 2, and 3. This is just rote learning at the end of the day. I'll bring out a table in front of us so that we can read through it quickly. So whilst they're defining hypertension down to 3 stages, they're talking about the clinic blood pressure, the ambulatory blood pressure, and the home blood pressure monitoring. So the clinic blood pressure is what we would get during our examination. May it be for high blood pressure, may it not be for high blood pressure, and we're doing the vitals and it comes about. Home blood pressure monitoring is something we'll talk about later in our episode, where we're struggling to diagnose high blood pressure, and that is our documentation at the end of the day. And ambulatory blood pressure monitoring is when we're suspecting someone to have high blood pressure, and we tend to give them it's like a radio-like device that they tend to wear on their wrist, and they go home and they wear it for 24 hours and we get the reading all throughout. So stage 1, stage 2, and stage 3. Stage 3 is anything greater than 180 by 120, so that's easy. Stage 2 has a bit of an overlap. Stage 1 is important for us because that's when we'll pick up high blood pressure for the first time when somebody's seen in the clinic. So it has a clinic blood pressure of greater than 140 by 90. So if we've got, for example, we're seeing somebody for not high blood pressure, somebody like who's come in with abdominal pain, who's come in with leg pain, who's come in with the musculoskeletal injury or anything of that sort, and we've got a clinic blood pressure of 140 by 90, that's when we should start getting alarmed and we should think about where we can go about from there. So stage 1 would be clinic blood pressure greater than 140 by 90, or ambulatory or home, doesn't matter, but the reading for that would be 135 by 85. And in between is stage 2 hypertension. Honestly, clinically, I haven't really clinically, what matters is if you can pick up stage 3, and if you can know where to send and what to do at stage 3 hypertension, and when to pick up high blood pressure or hypertension in stage 1. Stage 2 is just for theoretical learning in between. If you like learning stuff and you like learning numbers, that would be nice. So once we've staged high blood pressure, let's put down a clinical scenario. How does it happen? In 70% of the times, we have referrals from healthcare assistants and nurses who've picked up high blood pressure reading at one point and they wish for a GP follow-up. 30% of the times is when we're investigating for something else, for example, vitamin D deficiency or muscle weakness, something that's irrelevant to high blood pressure, and we've done vitals and we've checked the blood pressure just to see if the patient's vitally stable or not, and we've come up with the high blood pressure. Now, if you're in the clinical setting and you've got a first high reading, according to the NICE guidelines, the next step would be to repeat a reading again, and then to repeat a third reading, and then we document the lowest of the last two readings. So that would be our clinic blood pressure reading. If our clinic blood pressure reading is greater than 140 by 90, so that's where we start getting alarmed. Okay, there's a baseline hypertension in the background, and that's when we start investigating. Now from there, we've got two ways to go about it. Either we can arrange an ambulatory blood pressure monitoring. In the NHS, most of the times it's when people don't have blood pressure monitoring machines at home, and they're not keen on investing into it. So we can do the ambulatory blood pressure machine, which we send it over. We send a request via the NHS, and they get that radio-like substance, and we check the reading over 24 hours. The other way, if the patient's willing to get the blood pressure machine, would be the home ambulatory blood pressure monitoring. Now, with the home ambulatory blood pressure monitoring, we tend to target, ideally, it can be 3 days, but ideally it's 7 days. And we take 2 readings in the morning, 2 readings in the evening. And we've got a very nice chart for the NHS. I'll link it in the bio as well, that we can print off and send it, give it to our patients, or we can text it to our patients, or we can email it to our patients, and they can fill in the data. When that comes up, the ambulatory blood pressure monitoring, if given that it's higher than 135 by 85, it confirms hypertension. The home ambulatory blood pressure monitoring is a bit different. So we've got 7 readings of morning and evening. We discard day 1, and then we take the average of the upper values, the systolic blood pressure and the diastolic blood pressure. If that comes above 135 by 85, we confirm high blood pressure via home ambulatory blood pressure monitoring. So that's how we diagnose high blood pressure in a GP setting. Next up would be, how do we confirm the diagnosis? So this is how we've already confirmed the diagnosis with ambulatory or home blood pressure monitoring. So with one clinical reading of high blood pressure, we need at least either ambulatory blood pressure monitoring or home blood pressure monitoring to confirm our evidence for high blood pressure. Once we've done all of that, we want to look into a few things. The two most important things. So you've got a patient who's been referred either from the nurse, the HCA, or somehow you picked up on your consultation for something totally different with high blood pressure. They agree on getting a machine to go home and investigate into it, and you've got a 7-day home ambulatory blood pressure reading that confirms hypertension. Now we meet again 7 days later with the same patient. What do we do then? So we've got now we need to assess for 2 things: the cardiovascular risk and the end organ damage. I usually, when a patient's referred with high blood pressure reading via the nurses or the HCA, I tend to send out bloods first. So on my first appointment, I talk about I talk about the ambulatory or the home blood pressure monitoring. I check the blood pressure on my own, and then I talk about the home or the ambulatory blood pressure monitoring. And during this consultation, I send out requests for bloods and allow them to book in at the blood center to have their bloods taken. When they see me on my next appointment, usually they have the bloods with them. I tend to target HbA1c, UNEs, lipid profile. We send out a urine sample for albumin creatinine ratio. We do a fundoscopy and an ECG. When we meet on our second appointment, most of the times, according to the NICE guidelines, all these things are done. So we see the ambulatory care. So we check the urine if the ambulatory creatinine ratio is okay. We check the ECG if there's anything over there that's of concern. We check the fundoscopy to see if there's anything in the back of the eyes that you're concerned about, and we take a look into the bloods as well. Because we have the bloods during our second appointment, that's when we calculate the cardiovascular risk assessment as well. Usually, if you're using EMIS or System 1, if you type down the QRIS score, it tends to calculate on its own. And if it comes raised, that's when I start counseling regarding statins at the second appointment as well. During our first consultation, we need to talk about the high blood pressure symptoms. If the patient's young, we also need to rule out other secondary causes. So we need to talk about pheochromocytoma, renal artery issues at all, and we need to start looking into it as well. And when do we, the specialist to referral, when do we start thinking about referrals to the hospital or hypertensive clinics if you're working in the NHS? I usually send anybody under 40 to the specialist clinic to rule out secondary causes. If anybody's got end organ damage like retinal hemorrhages or life-threatening symptoms, that's when we send it. If the patient is unable to tolerate or we cannot fix in on the meds, that's when we send it forwards. And in pregnancy, we need to send it to specialist as well. So this is the first bit, or this is the first NHS, it's the first NICE guidelines for high blood pressure. In our next video, we'll talk about hypertension treatment, and we'll once again touch on the referrals again, with same day referrals, hypertensive clinic referrals, and how to go about it. I hope you liked this video. This is just somebody who when I was I find it hard, to be honest, to just read through PDFs after PDFs and to learn stuff. So to me, looking at a video, giving a summary of everything helps a lot. I hope this will help you guys, and fingers crossed it will make us better doctors at the end of the day. Have a nice time, guys. Bye.